Hello and welcome. India's public health crisis is significant, but the extent of that significance is something that we can only best understand with data. And more data is helping us understand why the COVID 19 crisis has perhaps been worse than what we could have otherwise expected or managed. To give you some examples, India has one government allopathic doctor for every 10,189 people, and only one state run hospital for every 90,343 people. Moreover, government hospitals in rural areas have one bed for 3,430 people, while urban areas have one bed for 869 people. Now, 63 million people, and there are many studies around this, were and are pushed into poverty every year due to health costs. 68% of total expenditure on health in India is paid out of pocket. The world average is only about 19%. So that tells you not just the extent of infrastructure deficiency when it comes to managing health challenges in this country, but also the fact that we are financially not strong enough, at least when it comes to the citizens' pockets. So to understand this a little better, Oxfam, the non-profit foundation, has done a research report called the India Inequality Report 2021, where they've looked at some of these issues and also tried to offer some solutions on what could be done in coming days. To discuss this, I'm now joined by Amitabh Behar, CEO of the Oxfam India Foundation. Amitabh, thank you very much for joining us. So tell us what, according to you, in this report was the most stark finding, particularly in the context of COVID 19?
So thank you, Govin. Let me say that COVID was like an X-ray, which exposed the fissures, the ruptures of the Indian health system. And I would say there are three big messages that we see. One is, and you've given the data for it, the enormous inadequacy of the health system. And I think that's a big story. We must take a pause and try and understand the inadequacy of the health system. The second, I think, which is critical, is that we need to also, unfortunately, again underscore that inequalities of the society are disproportionately affecting, and the growing inequalities further affecting the marginalized populations. Third, even during COVID, the experiences that we had were unequal based on your social position and your rural or urban positions. And fourth, I think, which is critical, I do think that we're pretty much driving with our health system uh, almost blindfolded. There's been this massive earthquake of COVID, but we have still not opened our eyes. And we are certainly moving towards disaster if we don't change the trajectory that we have taken. So I think the big message is that we need to fundamentally change our strategy of how we manage the entire health system in this country.
Right. So let's look at both these aspects. One is the infrastructure and what people can access or not access, whether they pay for it or don't pay for it. And the second is the affordability. So, what in your mind is the topmost priority at this point,
So in
given our
terms of
resources?
in terms of infrastructure, and we've seen that you've already talked about the doctors, and just to give you some averages, even the WHO says that we need one doctor for every thousand, and we have only zero point 0.6 doctors, and that is if you're really looking at the entire set of doctors of from Siddha to Ayurveda, etc. But as you pointed out, there's only one for 10,000 people. Um, Nurses, the WHO norm says that we need three nurses for every thousand, and we have only 1.7, which is almost a deficit of 43%. If you just move a little further, I think hospital beds are a important story. We have only zero point 0.5 hospital beds for every thousand, whereas the norm is there should be five beds. And just look at some of our peers. Even a country like Chile has two. Mexico has 1.7. Let me just give you. Bangladesh also is 0.87 hospital beds. And here I wanted to particularly highlight an important aspect that and which is very troubling. In 2010, we actually had nine hospital beds for every 10,000 population. And that's come down in 2020 to five per 10,000. So what we're probably doing is not keeping up with the increase of population, and that's really the big story. So and it just continues. There's more than a quarter of deficit in terms of the primary health centers, sub centers, and the CHCs. So it's a
Right.
serious story of infrastructural deficit, which then ties up with the question of actually investments in the public health system, which is extremely low. Yeah.
Right, and let me ask you about the incentive structure. So, assuming, let's say, out of pocket is paying for almost 70% or plus of healthcare in this country, there is, in some sense, an incentive for, let's say, private providers to create the infrastructure. And in that, if I would extend that, why would then, let's say, not enough beds be created, or not enough capacity being created, and what problem does that point us to?
Sure. So, I think that if you look at the rural-urban divide, then we will see that, the hospital beds, 70% of the population in rural is in rural areas, but it has only 40% of the beds. Similarly, the other number that we have is there's one bed in rural areas for 3,430 people, whereas in urban areas, it's 869. So obviously, it is probably the private sector which is doing its bit, small bit, to create the infrastructure. But what I would say is that it's fairly clear that the private sector is not capable of providing the uh, universal health coverage. And I think what's important is in this conversation also to bring in the government funded insurance schemes. Look at Ayushman Bharat. Let me just give you one data. Till October 20, uh, only 65% of the claims had been processed. So people who are under the scheme, 35% of them have not been able to get their claims. So it's fairly clear that this is not working. And then, just to on top of it, ultimately, if you look at the insurance schemes, which in some ways are supporting the private sector, unfortunately, instead of the public health system, is only for in-hospital inpatients, and most of the costs are actually for outpatients. So,
Right.
so from diagnostics, from medicines, so there's a fundamental flaw in the design itself.
Right, but the insurance is a way of supporting, let's say, the individual citizen in her or his quest for good quality healthcare. So, how do we make that insurance system work better, even as we fix public health and public health access? The second question is, if let's say 35% of claims are not being met, could it also be that there is a problem with the quality of claims themselves?
For Govind, I would be fairly saddened if a person who's taken a loan is anyways living pretty much on the edge of poverty. We tell that person that your form has not been filled properly, or you have not been able to give X document and Y document, and therefore your claim has been rejected. So I hope, as in on issues of health, we'll not get into bureaucratic hassles. But the first question, my sense is we need to get this the perspective differently. Insurance can at best be a small aid in providing health for all. It can be at best an aid for the universal health coverage, but it cannot substitute the public health system. I think that's where I think there is a
Right.
problem. The emphasis is completely on the insurance scheme, as if that can provide for the universal health coverage. Just let me give you one more data point, which again is very, very surprising, and I would say scathing for this regime. That this year, I'm talking of 21 budget, we have seen almost a 10% cut in the health ministry's budget from the revised estimates of last year. This is the COVID year. In that COVID year also, we have ended up reducing the budget of the health ministry. So there's in terms of the thinking, of how we
Right.
are planning our health system, there is a problem.
Right. Okay. Let me come to the inequality, which is of course the maybe the most critical point, or one of the most critical points. You've also pointed out in your report that higher income groups who had to arrange for transport themselves were, they were obviously in a better position to arrange transport for themselves, manage their own healthcare as opposed to low income groups. So, if we were to split the problem up, now this is a very large problem that India faces. So, if we were to split the problem up and say that okay, we want to help those who are the most disadvantaged get best quality access to healthcare, how could we then, or if at all, could we calibrate our efforts better?
So I think that's where the problem is. Why would we do a segmentation of the worst getting the best? I think the approach has to be universal.
No,
And
so what I mean is not that the worst getting the best. What I mean is that how do we, I mean, we will never be able to solve the whole problem at one time. So if we were to go sequentially, and maybe we want to focus on the most disadvantaged first,
I
which in
understand.
some case public health espouses to do, and then move upwards or onwards.
Sure. So that's really taking us to the key recommendations that we have. You know, One simple one is a significant enhancement in the public expenditure. And we've all been saying, as in successive governments, I think from the sixth plan, every government has said it should be 2 to 3%. Political manifestos always say 2 to 3%, and we are always around 1.25%. So, can we actually have the political will to make the investment of 2.5%? Because then it will sequentially start addressing a lot of these infrastructural problems. So I talked of the infrastructural problems from actually setting up those primary health centers to the sub centers to actually hiring of doctors to hiring of nurses, which I think is going to be significant. The second is, at least in the shorter run, though I would say, as I've already made my point clear, that investment should go into the public health system, but can we relook at, say, the Ayushman Bharat, where out of pocket expenses in terms of diagnostics, etc., should also be included? Because that's been one of the big problems. Again, one of the data points that we have is people pay for their medical bills 70% from their savings and 25% borrowing. So that's the level of the burden, financial burden, one sickness can have on the family. So that's the second. I would say I heard some passionate pleas just yesterday in the parliament for the right to health. I think it's critical that we start looking at least post COVID, honoring the fundamental principles of how our,
Right.
I would say, a welfare state has been designed, in which we must move towards the right to health. So there's some very, very concrete doables, but we need the political will to do that.
Right, and let me ask you a question, sort of, which goes from down to up. So, for every crore, let's say, that we got in additional health spend at a federal level or at a central level, where could that go in a manner that it is efficiently used, utilized, and bears fruit for those who need it the most?
So that's a tough one, but I would certainly say that it goes to infrastructure, uh, primary infrastructure, and also to the medicines and the diagnostics. So that would be the probably the first one. Let me also say again, in terms of the design, I've been talking a lot about the emphasis on, say, the private sector or the insurance. Even within the government budgets, the investments in the primary healthcare needs to be beefed up. So we cannot have great emphasis on tertiary care at the expense of the primary healthcare. So that would also be a very, very critical piece that we need to work with.
Right, Amitabh. And last question before I say goodbye. How long did the study take, and what's the kind of sample size and scope that you worked on?
So, Govind, one, if I could use your platform to say, people like us, we really need data, particularly on social policy. It's really, at sometimes I feel that the markets every quarter get the data, And I remember sitting with a former cabinet minister, and he was saying that you keep talking of social policy, but we get the economic data every quarter, so we can change our policy. And look at the health data. We are still waiting for the NFHS 5, and that really compromises our ability to come up with absolutely current picture. But we've
Right.
used the NFHS data, we have used the other studies, we have done our own survey, which was done in the November December period of 2020. So that's what we have worked with.
Right, right. Amitabh Behar of Oxfam India, thank you very much for joining me and hope to connect with you soon.
Thank you.